Okay, thank you everyone for joining me for the first topic in season 2 of my webinar series about degenerative cervical myelopathy, a condition you certainly want to detect in clinical practice and refer accordingly. And we're going to talk about why as we go. DCM is a condition that many of you who have been practiced for a while are probably noticing in your patients who are sort of aging with you. This is a condition that generally affects people who are older and something that we can look into as our patients sort of age with us in clinical practice. What I found in my practice, if you look generally, a lot of the patients you see are the same age as you. And that becomes important when we think about conditions like this. For those that know this term condition by its older term, it used to be called cervical spondylotic myelopathy. And that's what I was taught when I was at CMCC, but they updated the name a few years ago just to reflect the pathology a little bit better. And they changed the term to degenerative cervical myelopathy. So if I refer to DCM, you'll know what I'm talking about throughout this presentation. So there are problems with DCM, and a lot of them are in relation to its difficulty in diagnosis. So that's what we're going to talk about today. Unfortunately, there aren't any validated screening tools. As we'll talk about in a few moments, misdiagnosis or diagnostic delay is incredibly common, and that can drastically affect the prognosis and outcomes for these patients. The unfortunate part and the thing that we need to be critically aware of is that this condition can lead to irreversible neurological consequences if not diagnosed and managed properly. And it also presents quite a strong risk for neck manipulation, and we'll discuss that later on. There's also a general lack of awareness in healthcare about this condition, and that's something that we're going to talk about as we go as well. What we're going to cover for this, similar to other conditions that I've covered in this webinar series, we're going to talk about definitions in epidemiology, etiology and pathophysiology, assessment and diagnosis of this condition, natural history and prognosis, and then management. I just remind everyone to mute their microphones, please. I'm getting a feedback from somebody. Thank you. So let's start with the definition of DCM and the rough epidemiology. And when I get there, you'll kind of realize why we don't know too much about this. Degenerative cervical myelopathy is a clinical syndrome characterized by insidious progressive compression, torsion, and/or friction of the cervical spinal cord. And essentially, you can think of it as degeneration gone wild that ends up impinging upon the space for the spinal cord, which can cause any range of symptoms throughout the body, including the lower extremity that we'll talk about later. So that's just kind of an amalgamated definition from a couple of different papers, but I think it gets the point across pretty well. From an epidemiology perspective, obviously when something is not incredibly common, presents very variably from a clinical perspective in terms of symptoms, and is something that comes on insidiously over time as people age, it's difficult to get a good, accurate snapshot of how common this condition is. So obviously, and not surprisingly, there's some variability in the literature. The global prevalence, to our best guess, thought to be about 2.3%. We'll drill down into cervical degeneration in a moment in terms of how that affects, this sort of prognosis and the emergence of this condition. We do know, generally speaking, that it occurs in men more frequently than women. That might be a reflection of some of the risk factors for this condition that we'll cover later on. 10% of people over the age of 55 display some signs of DCM. And this is one of the challenges, is that there's no firm diagnostic criteria. We're going to go through an outcome measure that you can use in your practice to kind of quantify and score them in terms of their severity, and maybe to classify them in terms of what sort of DCM they have or what kind of management they might need. But that's one of the reasons why a lot of people display some of these symptoms. And our job clinically is to figure out who's who and then decide what to do with them. So this concept of DCM and the prevalence of it will certainly increase as time goes on with the aging population. So moving on to etiology and pathophysiology. If you think of DCM in terms of what it is, what the pathology is, and how it emerges, I think of it as lumbar stenosis in the neck. We discussed lumbar stenosis for those of you that were on the webinar. I think it was in April where we went through that, and I've discussed that in some of my online courses as well and at some conferences and things. But lumbar stenosis is, again, degeneration run wild that eventually bothers the spinal cord in a certain way, and DCM is the cervical spine equivalent to that. It can be congenital or secondary to degenerative changes, which I think is probably the more common syndrome that we would see in chiropractic patients. Again, with those neck pain patients you start seeing in their 20s, 30s, 40s that progress over time and have some degenerative changes. Anatomically speaking, the pathology is thought to be a combination of degenerative changes and ischemia. And we'll talk a little bit more about that in a moment. Ultimately, though, and I think this speaks to the variability of the symptomatology, it's not surprising that the pathophysiology is a little bit variable as well. So every patient is allowed to kind of have their own combination or constellation of symptoms or things that are happening in their cervical spine that contribute to this syndrome. But it's probably a combination of the following. The first is cervical spondylosis, and that's a progressive degeneration of the vertebral bodies themselves, the facet joints, etc., the spinous processes, as well as the intervertebral discs, facets, and the ligaments. And the primary one involved in DCM pathology is ligamentum flavum. And I'll show you a graphical or diagrammatic representation of that in a moment. This can also be from cervical disc herniations and not necessarily from an active nucleus pulposus out of the disc kind of herniation, but I think it's more related to what happens after. So a lot of people who have a disc herniation have advanced uncinate degeneration and other osteophytic changes at that level that can contribute to that symptomatology over time. So there's no real epidemiology tying people who have had a cervical disc herniation to future incidents of DCM, but I think logically speaking, there must be some connection there. And I think a cervical disc issue and cervical disc degeneration and ultimate herniation is just part of a degenerative cascade that would make someone a bit more likely to experience DCM. You see also reduced vascular supply of the anterior spinal and radicular arteries, and these can be stretched over the intervertebral disc or vertebral body itself. And this leads to ischemia of the nerve cells there, like the oligodendrocytes, or apoptosis and neural delamination. Nerve cells, like all cells, require blood supply, and in a sensitive area like the spine, any interruption of that secondary to degenerative changes that causes friction or overt occlusion of vascular structures can, of course, lead to symptomatology and deleterious neurological effects. There's also impairment of intracellular energy metabolism, and you can get free radical mediated injury, cation mediated cell injury, and right down to the physiological changes that can occur with nerve injuries secondary to these pathologies. When you look at it from a cross-sectional image in the cervical spine, there are a few different things. I'll point your attention to the posterior longitudinal ligament at the top. If you follow that down on the back side of the vertebral bodies, you can see how hypertrophy or thickening or changes in composition of that ligament can certainly impact the spinal cord itself. You also see between C3-4 and C4-5 there that there's some disc issues leading to protrusions or overt herniations that can indent on the PLL and also the thecal sac and the spinal cord. You can get ossification of the ligamentum flavum as well on the posterior side if you look about 2/3 of the way down between C5, 6. So it's sort of a collection of things that can impact what's happening with the spinal cord as it's trying to happily traverse down the spine to send and receive signals from the rest of your body. You see also at the bottom at C6 there hypermobility and listhesis. And in the prognostic literature and risk factor literature, you don't see much about spondies and these kind of instabilities that people can have in their cervical spine. But I would have a hard time believing that that isn't an important contributing factor there as well. So those sorts of things tend to emerge clinically in younger patients, of course, but something to keep in mind if you have it in their history or if you've treated them for it in the past. When you look at it from an imaging perspective, as you know, degenerative changes are incredibly common in people in the cervical spine and throughout the spine, quite frankly. About 70% of people over the age of 65 have degenerative cervical disease, or what would be considered possibly clinically significant. And spinal cord compression is actually present in 25% of those people. Now, not everyone with spinal cord compression has overt symptomatology of DCM, like all the symptoms I'll take you through in a little bit. But I think it's important to understand that people of, as they get older, you might be dealing with someone who has some cord compression that's asymptomatic. And that's a little bit concerning from a manual therapy perspective. And that doesn't dictate that we all take advanced images of people's necks and so on. But it's just something to think about with your older patients, particularly patients that you haven't seen previously or monitored over time or have a baseline neurological status for via your clinical examination. What we also see is by age 50, about 1 in 3 people have cord compression on MRI. So that tracks with the stat from the last paper. That increases to 2 out of 3 in those over 80. And that's just secondary to chronic degenerative changes that come with age, generally speaking. About 1 in 5 have with cord compression develop myelopathy. So I've told you that a certain chunk of people have cord compression, and it's about 1 in 5 of those that actually develop the myelopathic symptoms or signs that we'll talk about later. Cord compression can also include, like I said before, conditions like ossification of the posterior longitudinal ligament, or OPLL. And again, a small percentage of spondylosis progresses to DCM, but it's in our clinical interest, in the interest of the patients, of course, to identify them accurately. From a risk factor perspective, the literature is pretty broad on this. And again, I think that ties into the general variability from a clinical perspective. And also, everyone's an individual with a certain combination of risk factors or activities or injuries that they've sustained over time. But they've split them into static, dynamic, histopathological, and general. So static is congenital stenosis. If you're born with a narrow spinal canal, you're more at risk for this condition, just like you are in the lumbar spine. If you have a cervical disc herniation, like I said earlier, that shows up just a little bit in the literature as a relationship there. And then ossification of the ligamentum flavum, or posterior longitudinal ligament. The dynamic stuff is what you have to kind of ask them about. Like, what have you done occupationally and athletically with your cervical spine and spine in general? Looking for things like repetitive strain, cervical hyperflexion or extension. And you could add motor vehicle collision injuries to that as well, depending on the mechanism and how the incident occurred. And remembering that nerve roots can be stretched over degenerative structures, and the spinal cord can as well. And it's that friction that can lead to ischemia or overt compression of those neurological structures. From a hyperextension perspective, if you have a calcified or hypertrophied ligamentum flavum, that's when it can park itself in the spinal canal, which is obviously a problem from a dynamic motion perspective. Histopathologically, mechanical compression can lead to ischemia, of course, cutting off blood supply, like I mentioned earlier. This can also promote inflammation and lead to things like neuronal cell loss, compromised blood-brain barrier, demyelination, astrogliosis, and axonal degeneration. So all kinds of cell-related neurological deficits can occur there. General risk factors, again, this is more common in men than women. I didn't give you a great number on that because I don't think there is one, quite frankly. But it's something to keep in mind for people that had a labor-intensive occupation as well. And that can include motion, that can include loading, that can include exposure to vibration, which ties into disc pathology as well. From an assessment, diagnosis, and differential diagnosis perspective, one of the problems that we have with DCM is that diagnostic delays are very common. The literature bounces around in terms of numbers. So for my survey of the epidemiology papers and the scoping reviews and that sort of thing on this condition, it averages out to about 6 years. And the problem with that is it, of course, delays proper management. And proper management for a lot of these patients, unfortunately, is surgical to stabilize the area and release pressure on the spinal cord or the nerve roots or what have you. So, one of the problems and one of the reasons for this diagnostic delay is that the signs and symptoms can be vague and emerge over a long period of time. I've actually, as many of you know, I do medical legal consulting when chiropractors get involved in legal disputes. And I was on a case a number of years ago that involved DCM. It was so long ago, we called it cervical spondylotic myelopathy, but the lawsuit emerged because the chiropractor missed it. And, there were emerging neurological symptoms over time that the chiropractor noted in his file in terms of clumsiness that we'll talk about in a moment, paresthesia, and he didn't really complete a comprehensive neurological exam, kept adjusting, kept adjusting, kept adjusting. And I believe, if I'm not mistaken, it was treatment number 178 that this guy had given this patient over a 23-year period that the patient had an acute reaction to, like full myelopathy, symptoms emerging, inflammation around the spinal cord. He needed 2 surgeries and ended up suing the chiropractor. So, this diagnostic delay is something that I'm going to circle back to at the end. I really think we can have a strong influence and a big impact in diagnosing this condition early and getting the people to the proper care that they need, or not giving them care that could harm them. And I think that both of those things are equally important for us. So, identifying patients early is critical. It can facilitate proper care management and referral if needed, prevent deterioration of symptoms, and preserve quality of life. And as I'll mention later on, DCM, of all the chronic conditions that have a musculoskeletal component, is known to be one of the worst in terms of long term quality of life impacts for patients. This is really not a fun condition to have. Now we get to the more important things, I think. I always say epidemiology doesn't mean much to the patient sitting in front of you, but that last section hopefully just gave you an idea of what we know about it from that perspective. This is what we know about how it presents clinically, and this is the important thing to keep in mind in the take home from what I want you to get out of this talk today. Initial symptoms are thought to be the following, and what I'll do first is put an asterisk on everything I'm going to tell you because, again, that literature is kind of variable. We don't have a lot of massive studies on this condition, partly because it's kind of rare, partly because of the variability in diagnostic presentation and criteria. But from what we know from putting the studies together done in the last 10 years or so, and I will add that we are starting to see more studies on this because of the aging population, increased clinical recognition, and so on. But what you need to look for are uni or bilateral symptoms. I think I used to see in the literature this idea that the symptoms had to be bilateral, but I don't think that's the case anymore. But one thing that you should be asking a lot of your aging patients about, and I don't want to put a number on that, but let's call it 65 plus, is are your hands working properly? Do you ever notice that you're dropping things? Are you clumsy? How's your dexterity if you need to tie a shoe or so what you might see in people's hands is a reduction in dexterity, and that's thought to occur in about 3 out of 4 of these patients. That's actually a pretty common symptom. It can also include things like sensory changes, and that can be pain, temperature, proprioception, or general dermatomal things. And as I've noted in many of my presentations in the past, patients don't read the anatomy textbooks in terms of their dermatomes. If you can find a dermatomal pattern, then high five to you, and it makes things a little more clear. But patients' anatomy is not that consistent, generally speaking. So don't get married to this idea of finding a unique dermatomal pattern. That doesn't mean you shouldn't look for it. What we see generally is that this dexterity issue in the hands, the sensory issue in the hands happens first. That's not across the board, but that's the most common presentation that's been documented. And then if it's going to progress, then it will come down to the lower extremity. And then you start looking for things like gait instability and falls. If you have an older patient who's like, you've been seeing them for years, there's a bit of a gap in care, they come back when they're 60, 65, you haven't seen them for 7, 8 years. Like, oh, how are you? Well, I'm sore a little bit because I've had a couple of falls in the last year. Oh, really? Tell me a little bit more about that. Because if there's a marking in the sand where their balance was okay and then all of a sudden it wasn't, that doesn't mean they have DCM, but that means you should start looking for that sort of thing. And I think it's important for us to keep all of that in mind. So falls are incredibly important. I think I might actually do a webinar on falls in the second half of this season, because I think that's, as a side note, something that we can have a huge clinical impact on from a treatment perspective, but also from a rehabilitation and balance training perspective for older people. But I'll leave that for another day. but something that we do have to inquire about and be cautious of from a DCM perspective. For us, we also know that neck pain is incredibly common as people age, and also shoulder pain is too. And you see as in half and 40% of these patients, they have neck and or shoulder pain. And radiculopathy that appears as kind of a unilateral radiculopathy appears in about 40% of people too. If you think of radiculopathy, most common cause is disc herniations, whether it be in the neck or the lumbar spine, and those tend to affect younger people, right? So if you're seeing someone in their 60s present with a radiculopathy pattern, you might want to start looking for degeneration from an older disc problem or other global degenerative changes that we've been talking about today. So that's an idea of some of the initial symptoms. For those of you that read my or listen to my research reviews, we reviewed a scoping review of DCM symptoms that was published in 2024. They just looked broadly at all of the case reports, case series, and trials published in the literature and looked for the most frequent symptoms. What they found was the most frequent symptoms of DCM include unspecified paresthesia. And again, we're back to the hands, hand numbness, clumsiness, weakness, and then gait impairment. I think gait impairment shows up as one of the most common symptoms there because I think people miss the other stuff before the gait impairment shows up. So it stands to reason, at least in my opinion, that a local degenerative change in the cervical spine before it affects the spinal cord could affect the nerve roots or what have you. So you'll see this kind of uni or bilateral changes in nerve function in the hands or a radiculopathy symptomatology before you see the myelopathic changes in the legs that may affect balance or pathological reflexes or some of the other things that we'll go through in a moment. From a signs perspective, what to look for clinically, you're looking for things like muscle weakness, atrophy. You never, new or different fasciculation or contraction patterns that they didn't have before, especially with intentional movement, hyporeflexia or absence of reflexes, or hypotonia in muscles as well. So you're looking really for any change to normal muscle tone, function, and contraction patterns when you move or when they move. Upper motor neuron signs that we can review here include weakness. From a DCM perspective, again, the peripheral neuro stuff shows up in the upper limb, the clumsiness, the sensory, the paresthesia, and then the upper motor neuron signs start showing up in the lower extremity, and that can be weakness of the psoas quads most commonly, which can alter gait, lead to more falls, like I mentioned a moment ago. And over about 80% of DCM patients are experiencing more falls. And again, I think that represents a diagnostic delay, not necessarily a first symptom. So if you have someone who's all of a sudden falling more, one of the first things you should look for, especially if they're older, is DCM as a presentation, rather than focusing on the lower limb, for example. Other upper motor neuron signs is hyperreflexia. Remember, local peripheral nerve problems reduce reflexes. Upper motor neuron problems remove inhibition and give you hyperreflexia. Hypertonia is also possible. I think that generally happens after hyperreflexia in my experience. You can look for things like a Babinski sign. It's generally considered to be 100% specific for DCM, but it's not always present in DCM. And remember, when you record these in your files, you only write the word Babinski if it's positive. If they have splaying or abnormal response in their foot, if they don't, please record it as plantar response is normal. Because if we have to do a file review or if a lawyer gets their hands on it, they might confuse what you meant there. Then there's Hoffman sign. I'll show you that in a moment. That's present in about 80% of patients. There's also the Tromner sign that appears in the literature, which is really just a Hoffman sign flicking the other side of the finger. Those tests, when I get to Hoffman, I'll talk a little bit more about what we're actually doing there. Clonus is when you take, the easiest way to do this is dorsiflexion of the foot or plantar flexion. You sort of move them quickly and look for them just kind of fighting against you or contracting against you in a repetitive pulsile manner. And if there's more than 3 beats, that's considered to have a high specificity for DCM, but also low sensitivity. It's not always present. A clinical test that's highly sensitive is positive in most of the cases where the condition is present, just to review. Less common, but something to ask about. And I think in a general neurological screen, you tend to ask patients about this anyway, are things like bowel and bladder dysfunction or sexual dysfunction. Sexual is not as common in DCM. Only about 4% of patients have issues there. But bladder is pretty common and bowel is decently common for, again, the best that we can discern from the literature in terms of the epidemiology of it. From a physical exam perspective, if you're suspecting DCM in your patients, they of course deserve a full upper and lower limb neurological, including sensory, motor, and reflex exams. You want to check their cranial nerves. You'll notice that, cranial nerve function doesn't really show up in the symptom list for this because it's above the area of pathology. But I think with all of your older patients, it's a good idea to do a full neuro sometimes. I think it's a bit less critical in younger patients, depending on what their clinical presentation is. Of course, if they have something that would warrant that, I'm not saying don't do it, but what I am saying is as people get older, I think it's in your best interest to have a baseline neurological exam result in your mind about how their nervous system functions. So, in patients who are older, who are new to you, I think it's important to get that baseline. Then we have all these special tests. And look, none of these are perfect at all. They haven't been tested from a parametric perspective very well for this condition in terms of sensitivity, specificity. However, they all kind of point to this same idea. And the idea is that the nervous system isn't working properly. And so myelopathy hand is one of the things you can look for. It's characterized by a positive finger escape sign, which means their fingers just kind of drifting a little bit, like it's just kind of going where the other fingers aren't. And a grip and release test. People should be able to do this quickly, 20 times in 10 seconds. So any patient, even if they're older, should be able to do this pretty quickly. People with myelopathy or severe radiculopathy affecting their upper extremity are a little bit slower, and that's just an indication to you that their motor system isn't really functioning properly. The other thing to look for, and as I've mentioned in other courses, intrinsic muscle wasting in the hands or feet are kind of a late stage sign of motor problems. That's not the first thing that's going to show up. It takes time to develop and for those muscles to waste. But if you do see intrinsic muscle wasting in the hand, it can be an important sign for this. What I'll also say is that as people get older, they kind of lose their intrinsic muscles in their hands anyway. And partially that's because they may not be as physically active, they're not gripping things. So the muscles, part of the general loss of muscle mass in older people also affects their hands. So if you can, look for a difference side to side, but recognize that they might just be atrophying on both sides. So, and if you don't have a baseline for that, then it's hard to really judge. Then we have things from a special test perspective like Hoffman and Tromner. I'll show you the Hoffman sign in a moment just to review. And then there's the inverted radial reflex where you do a distal radius tap. And instead of seeing elbow flexion, so if you aim for the distal brachioradialis tendon, it should flex the elbow a bit. The inverted radial reflex is if you tap there and the fingers go. That just means that the nervous system doesn't know what to do with that information. We have our plantar response again, and again, it's only a Babinski if it's positive. If you see toe splaying or extension when you scrape your reflex hammer across the bottom of their foot. Foot clonus with rapid dorsiflexion. I mentioned 3 beats a moment ago. That's hard to perceive sometimes. If you've ever had someone with true clonus, it's very difficult to count the beats in a clonus. So I'm not expecting you to do that, but you know it when you feel it. And for those of you that have seen it in your practice, you know what I'm talking about. But the way you elicit it, if is to do that dorsiflexion pretty quickly, like put a bit of strain through their calf muscle and see how their nervous system responds. Romberg test, there are tons of variants. You can do it standing, you can do it marching. You can add a pronator drift test to it as well. You can do it with your eyes open to test balance, then close the eyes. That's a traditional Romberg and see what happens. But in the literature and in clinical textbooks, there are a variety of different ways you can do that. Heel toe walking is another one, or tandem gait. That can actually be a good general screen for balance in older people as well. So it's not a bad idea to use that one as general practice. So Hoffman sign, you can flick the nail, the back of the nail, and what you're looking for is like an abnormal reaction of the nervous system. If you flick your nail it shouldn't really do anything. Your nervous system shouldn't interpret that as input that requires a motor response. But a Hoffman sign is just testing for an overreaction there. And again, that shows a reduction in inhibition, which is generally a longer track myelopathic sign. So you can use your finger and flick it that way, or you can flick it as this person's doing in the image on your screen. Tromner sign is now thought to be one of the better tests for degenerative cervical myelopathy, and it is literally the same test, but you flick the palmar surface of the distal finger. So this is what I said earlier. These tests, there's nothing special about the middle finger. You can do this to any finger. Quite frankly, the reason they pick the middle is that so you can see her index finger moving. So if you do it to the index finger, you may not see the rest of the fingers flex, but you can sort of do this to any finger. If I found a positive one, I would test it on every finger. And in my experience, you'll see that it does it no matter what finger you do it to. And the Tromner is just doing it on the other side. So you're looking for, again, an inappropriate overreaction from the nervous system to a general input that it shouldn't react poorly to. There is a tool you can use in your office to score this. It's called the Modified Japanese Orthopedic Association, or the MJOA outcome tool. And what I'm going to do for everyone who has a ticket for this, I will, when I send you the slides and the recording early next week for this, I will include this tool for you so you can keep it in your office. It's a series of questions and signs and symptoms that you put a grade to. It has a scoring chart on it, and it grades motor dysfunction in both the upper and lower extremities, sensation and urinary function, and then characterizes patients as mild, which is a score of 15 to 17 on the MJOA, moderate as the score gets lower, or severe. So the lower the score, the worse the person's condition is. This has been tested insofar as we can test it in a huge population. So what we know about it is that, generally speaking, if the person scores under 12 on this instrument, it's even a poor recovery post-surgery. So that's one of the things that we know here. There are a couple of others called the Neuric Scale, Prolo Scale, and Myelopathy Disability Index. If you're going to pick one, I think the MJOA is easier. I think it's a bit shorter to use, and I think parametrically it's just as good, if not better, than the other ones. That's why I recommend, if you're going to employ one of these in your practice, use that one. And again, I will send that to you. From an imaging and diagnostic perspective, plain film x-rays are first line still for most things, albeit it may not be the most ideal way to look at this. But you want to look at their canal width, basically, in a sagittal plane. The Torg-Pavlov ratio was kind of the older term. I think in my generation, that's what we learned. They use cord canal mismatch now. It's sort of the same concept. But if the canal is less than 0.8 of the width of the vertebral body, that's thought to indicate stenosis. What I think is a bit easier, depending on the size of the person, that's kind of the problem with all these things. Some say in the literature that a canal width of 12 to 13 millimeters or less represents canal stenosis. Now, just because someone has canal stenosis does not mean they have DCM, obviously, but that's just, we're working towards putting some pieces of the picture together. Okay, next we have CT scan, which is, if you can get it, great. It's usually more easily accessible in most places in Canada and in most places in the world, but MRI would be the gold standard. And part of the diagnostic workup here is to rule out other differentials. We'll go through differential diagnosis for this in a minute. But one of the biggest mimics of DCM is carpal tunnel syndrome. And that is kind of common in older people too, for a variety of reasons, depending on their occupation, what they did from an activity level or previous injuries and so on throughout their arm, shoulder, or wrist and hand. But DCM often shows up as bilateral carpal tunnel syndrome. So a nerve conduction velocity study can help rule that out. And other things we need to be concerned with because of this constellation of neurological symptoms that can show up are kind of the dreaded things like multiple sclerosis and ALS. So sometimes there's a bit of confusion about that. So further diagnostic testing can help sort that out. From a diagnostic perspective, unfortunately, I don't have a perfect algorithm for you. There's no consensus criteria for this that I could find anyway. But one of the things that I think we can keep in mind, and I put this together from an amalgamation of recommendations from some of the authors that publish about this, is that a diagnosis of DCM can be made if you have one or more symptoms and signs. So any of these, things like hand clumsiness, imbalanced gait, or increased falls, you could add there as well. Numbness, weakness, or bladder dysfunction, and other things like fine motor dysfunction, clumsiness, dexterity changes in the hands, hyperreflexia, gait ataxia, sensory deficits, or focal weakness, that you can track back to the cervical spine and then add some confirmation with that with MRI. I don't think we need imaging to make this a working diagnosis for a patient, but I also think you always want to get some imaging for these patients. If you're suspecting that one of your patients has DCM, I think x-rays are at least a minimum to view and obtain. And I don't say that for many conditions that we should image, but I think if you're suspecting this and they have a constellation of symptoms that's making you concerned about this, I think baseline imaging is a good idea. And the way I think about that is, how does it look in a legal case if you didn't get imaging and tried to treat them in any way, shape, or form while they are clumsy, have gait problems, paresthesias, and so on? So I think it's just best practice to seek some imaging for these patients. The Lannon and Katcher paper from 2021 has a diagnostic summary there, or a thought process that we've covered primarily here. You're looking initially for subjective or objective signs or symptoms in terms of paresthesia, decreased dexterity, gait instability, urinary incontinence, etc., or the signs that you get clinically from an objective perspective: a Babinski response, hyperreflexia, positive Hoffman or Tromner's, clonus, proprioceptive changes via Romberg's or other balance testing, and hand dexterity. If they have those, one or more, you have to put in context whether one is enough to seek imaging. That's up to your clinical judgment. It depends what the sign is. It depends on the constellation of other things that they have, or your experience with this patient, or what you understand about the level of degeneration in their spine and how that might be contributing in terms of deciding whether to get an MRI. If you get the MR and it's clear, and there's no evidence of significant spinal cord injury, you can work up for other causes as you see fit. Again, some of these things need ruling out, quite frankly, like MS and ALS and so on. And granting that that's been done, you can do a supervised trial of treatment. We'll talk more about treatment in a moment. If the MRI reveals changes, then doing an MJOA outcome measure, if you haven't done that already, will give you some idea. And again, the lower scores, you go from mild, moderate to severe. Severe is a surgical referral. Moderate, also a surgical referral. But here's my advice to you as chiropractors. I think if you're relatively certain that a patient has this, or at least is in the early stages of this, or whatever stage, quite frankly, I think they should talk to a surgeon just so they know what's coming for them and what their options are from a treatment perspective. I don't like to bother surgeons with needless consults. They're busy enough already, but I think this particular condition that shows up in our offices is severe enough for us to warrant seeking that referral and being pretty diligent about getting it. From a differential diagnosis perspective, that's kind of a broad list. When you have something bothering the spinal cord and presenting symptomatically because of that, you start thinking about things like space-occupying lesions, different types of cancer, tumors, and so on in the head and neck area. We've already mentioned multiple sclerosis and ALS, which are, of course, quite severe things that would need a neurologist to diagnose as well. You can check them for carpal tunnel syndrome, but what I would mention there is that it's a common mimic of DCM, and it can be present at the same time. It can be part of the symptom constellation of DCM, as can any other peripheral nerve entrapments in the upper extremity, radial tunnel syndrome, and so on. And again, in an older patient, when you see that, you have to start thinking towards the spine, I think. Younger people get carpal tunnel and elbow problems, golfer's elbow, and so on from repetitive strain and sports participation. And maybe that's the case for some older people, but I think you have to put it in context of what they're doing with themselves, what the mechanism of injury could be, what activities they're doing repetitively, and how that might strain the involved tissues. So just keep an eye out for carpal tunnel syndrome in older people. And if it's not responding to care, if they have any other version of the symptoms that we've talked about today, it might be worth thinking a little bit more about DCM. And I think that's part of the downfall in healthcare and the diagnostic delay for this condition is rather than being one of the first things we try to rule out, it's one of the last things we land on from a diagnosis perspective. The other thing you can have is normal pressure hydrocephalus, which can also show up with cognitive disturbance, trouble speaking or swallowing. That one would be referred, I think, if you're having those symptoms in your office anyway. And then if you look physiologically, some of these neurological signs and symptoms could be vitamin B deficiency, and nutritional deficiencies aren't uncommon in older people, so it's something to keep in mind. It wouldn't be my first guess necessarily, but if you've effectively ruled out other things, vitamin B deficiency specifically, and specifically in elder people, shows up with fatigue, cognitive disturbance, glossitis, and visual changes. So the symptom pattern is a little bit different there, but something to keep in mind for sure. So, from a natural history and prognosis perspective, what do we know about what happens to these people? Well, you shouldn't be surprised by now that DCM's natural history is pretty poorly understood, highly variable, and difficult to predict. But what I can tell you is what I mentioned earlier is that DCM comes with very high levels of unemployment, actually. So the younger the diagnosis, the worse this is, of course. And that's a reflection of the fact that you're still in the workforce, because some of the patients who develop this are retired by that age. But it's really, really hard to work. Of course, if your upper extremity isn't working properly and you have leg symptoms and you're tripping and falling and you have dexterity issues and so on. We also know that among long-term conditions, DCM has some of the lowest quality of life scores. So as you can imagine, it's not fun to have this condition. Without proper management, it tends to get worse, even though some patients have this kind of waxing and waning of symptoms where it'll appear, it'll be diagnosed, and then they kind of stabilize for a while. It's kind of like lumbar spinal stenosis that way. The progression over time is quite variable, but the long-term trajectory is generally a worsening of symptoms. And about 3/4 of these patients report, like I just said, non-consistent episodic changes with some even asymptomatic periods. They may see some improvement in their arm function and so on. I think that concept complicates things for us a little bit, doesn't it? Because if you're working with another differential diagnosis in mind, like an isolated root-specific radiculopathy, for example, and then they improve with care, but that might be just because it was a decrease in the symptoms of DCM, and you may miss thinking about DCM as a possibility for the radiculopathy in the first place. So one of the reasons I wanted to cover this is because there are a lot of landmines in this progress of this condition for us as chiropractors. And I think if it's not on your mind as a differential diagnostic possibility, it's easy to miss. And like I said, I have seen that in a pretty expensive legal case before. From a prognostic perspective, we know some negative factors here, and I think this applies to a lot of conditions. First is the degree of disease progression at diagnosis. The later you find this, the worse the prognosis, and also the duration, the longer they've been symptomatic, and the younger age they are at diagnosis. If this pathology shows up in a 40-year-old, they're going to have pretty advanced changes by the time they're 60 and 70. So all of those things are considered negative prognostic factors. Ultimately, a lot of these patients go on to surgery. We know that there are some prognostic factors for patients who undergo the surgical treatment for this, which is usually some degree of debridement, stabilization, hardware, that sort of thing. It varies depending on the person and the surgeon. And that can be age, symptom duration, and also preoperative neural function. The worse their function prior to surgery, the worse it's going to be after. And that makes sense. That's applicable to most spinal surgical cases, regardless of the initial pathology, quite frankly. Progression of DCM or CS, sorry, I have CSM. This is an older point from this slide. Only some patients progress with myelopathic symptoms. So I guess part of our diagnostic challenge is to catch this before they have myelopathic symptoms, which is almost making the diagnosis before it exists, if you know what I mean. Recognizing that some people just exist with the upper extremity symptoms and don't progress to the myelopathy. So again, it's putting all the diagnostic pieces together and all the information that you have in terms of their presentation, your prior history with them, and their response to care and so on. From a management perspective, it's critical for us to diagnose this early and monitor progression over time. And just to park us in the management literature for now, my job is to look at papers and help you apply it to practice. Unfortunately, we don't have a ton of management data on DCM as a condition itself. So there's not a lot of research to go here. There are a lot of suggestions and a lot of sort of disagreement about those suggestions, quite frankly. Bed rest is an interesting one. It shows up a lot. That's not a long-term strategy for anything unless you want to die, quite frankly. But it could help people get through acute episodes and so on. Remember, for a lot of these DCM patients, the signs go up and down over time, symptomatically. There are some medications that varies from neuroactive medications to painkillers and so on, but it's really hard to live on those for a long period of time. Some clinicians like to use steroid injections or other type of injections. There's exercise, which to me would be part of the approach anyway, is trying to keep them mobile and strong to the best of our ability. Some people suggest soft or rigid collars, but the general consensus in the literature is that's unlikely to help. And that, I think that's representative by the fact that you don't see many people walking around with those. For those of us who were born in the late 70s, the 80s and 90s were full of people walking around in neck cushions after car accidents, wasn't it? Then there's, pardon me, cervical traction. It's funny, in the literature, some say to try this and some say to avoid it. We'll discuss what we do to these people in a minute because there's some risk involved in putting your hands on these people, I think, because of course something's bothering their spinal cord. And if you move their head and neck around and bother their spinal cord more, bad things can happen, unfortunately. But other advice in terms of management includes avoidance of risky activities or environments and heat cold thermal therapy. We have no evidence here relating to manual therapy. Again, the case I was on was a unique thing. It wasn't that the chiropractor was trying to harm the patient, of course, just the chiropractor missed some subtle signs along the way that indicated that this person's condition was more severe than it was. In that chiropractor's defense, the patient always wanted treatment, always wanted adjustments, thought it was helping. And the punchline there is it was helping until it didn't. And it was an unfortunate scenario all around, but I use it as a cautionary tale for you in practice. In my opinion, from a pure risk management perspective, if you know that people have degenerative changes that are bothering their spinal cord, and especially if it's emerging in lower extremity symptoms, this is kind of a no-touch scenario for their cervical spine, at least from a movement perspective. You can still do soft tissue. The traction thing is interesting to me because if it feels better and it's not provoking any neurological symptoms at the time, you could try it. I mean, it's just the rotation and the movement and moving degenerative things around a bothered spinal cord that really seem to be the thing that stands out to me. You have to talk to patients about this condition. In terms of insofar as we know very little in a way about prognosis, I think in a chiropractic environment or a physiotherapy environment or family medicine, quite frankly, if this is the suspected working diagnosis, I think it's advanced imaging to quantify it or rule it out, quite frankly. And if it's there and the imaging correlates with the symptomatology even a little bit, I think it's worth seeing a surgeon, even if they're not acutely surgical at that point. I think it's get them on the surgeon's roster, get them talking to the surgeon about what their options will be if things get worse. And I think it's something that we need to be mindful of and push for, recognizing that when you get referred to a spine surgeon in many parts of Canada and around the world, you're waiting for a number of months anyway. So getting in that queue could be important for them. Surgery is recommended for moderate or severe cases and a consult at the very least. And from our perspective, the reason I wanted to highlight this in a webinar format is that we miss these cases. And unfortunately, if things go south for them from a symptom perspective, we can also be blamed for that. And it's kind of specialist level diagnostic things, doing all these special tests and everything. But I think we're all very capable of doing this, very capable of recognizing the symptom patterns when they're there and reacting accordingly and documenting accordingly, of course, please. So all of you in practice have complex neck pain patients. People have been in a couple of car accidents, had some concussions, maybe have some early degenerative changes to their neck, chronic neck pain, stress, muscle tension, all of that. And as you follow them over time, what I can recommend for you, please, is be aware of and ask them periodically about neurological symptoms. And I do this for a couple of reasons. I want you, as their doctor, to be aware of their neurological status. And trust me, I understand how easy it is to ignore this sometimes. When you're seeing this patient that you see every 3 months for a maintenance appointment, all of a sudden you look in the file and it's been 3 or 4 or 5 years or 6 years since you've done an evaluation on them, because you only see them once in a while. It's pretty standard. They feel good. They come to see you when they need you. That kind of patient, I think it's in our best interest to have some markers in the sand in terms of neurological function over time. So I'll remind you about that. As I'm reminding you about that, I'll remind you about updating informed consent. As of the time of this recording for my colleagues in Canada, we have a brand new consent form. If you're not using it now, you should be. So just a reminder about that. But while you're updating neuro status on people, in your file, it's always a good idea to document consent as well. Always remember, with my medical legal hat on for a moment, try and write your files as a story about what you're doing with the patient, how you're assessing them, your thought process, how they're progressing, and so on. And write it in a way such that I, your friend and colleague, Dr. Sean, can explain to a judge why you did what you did. That's kind of the job of a med legal expert, is to explain to the court the thought process, whether the standard of care was met, if the care was appropriate and indicated, if they were monitoring patient outcomes, and if they were responsive to new signs and symptoms. And this condition falls into that last point. It's emergence of new signs and symptoms that you need to respond to accordingly. So always monitor neuro status in your aging neck pain patients. And if it's present and symptomatic, don't be afraid. Even if you've been treating them and then you discover it's there, get it assessed, diagnose it, talk to them about change in management with the emergence of new information, communicate with your patient and get them in the proper line of care. So that's what I have for you about differentials and clinical considerations for degenerative cervical myelopathy. I have 2 more webinars posted for the remainder of 2025. The next one is Thursday, November 13th. And we're going to go through differential diagnosis of facial pain. And we'll talk about some TMJ things and other conditions that can affect the face. The December webinar is about some research updates in the world of migraine. So diagnostic considerations and management considerations. While I have your attention here via the live broadcast or the recording, I always have topics in mind. I'm going to do, I think, 5 or 6 more of these before June 2026, starting in January. If you have a topic you'd like me to cover, please feel free to suggest something that you'd like me to look into. What I like about these webinars and what is encouraging for me to see is that people show up repeatedly to these. So you kind of like this format. And it's a format people have asked me for a number of years. It gives us a chance to kind of look at some more obscure things that can be covered in an hour versus like the broad topics like stroke and neck manipulation or mechanical back pain and that sort of thing. So I do like the topic variability here. So please feel free to suggest any topics you might have in mind. This degenerative cervical myelopathy section, or a 4-year-old version of it at this point, is included in the Older and Bolder Chiropractic Care for Healthy Aging e-seminar. That's an 8-hour program that includes sections on chiropractic care for older people in general, what we know about manual therapy for older patients, osteoarthritis, lumbar spinal stenosis, and degenerative cervical myelopathy. It's one of my most popular programs. I know many of my regulars on the call here have probably already taken it, but for those who have not, it's a great program. It's video-based, it's online, and it's on demand. As always, stay in touch. I'm not a hard person to find. Make sure you follow me on social media. I'm at Dr. Sean Thistle on all the major outlets there, Facebook, Instagram, and LinkedIn. And what I can do now, I'll end the recording in a moment. So thank you, all of you, for joining me for this broadcast today. I look forward to seeing you at future webinars, and I'm happy to stick around for a few questions if anyone has any. But for the purpose of the recording, I'll end here. So thanks for joining me, and feel free to stick around if you like. See you next time.